Good morning, one and all. So I hope all of you are now settled after a tough phase of undergoing various postponements, hardships, struggles, and all these things. And also, you would have done and like that's like a sort of like a relaxed feeling now. So now let's start this recall from our ADrPlexus, this pathology recall 2004-24 NEET recall. So basically, if you ask me how was the exam? So people are used to say that session one is the questions are a little bit simple, and session two is it's more of complicated and long, lengthy questions. All these sorts of things. It's the responses are coming. Okay. So now, if you ask me, the questions actually, yeah, I agree. The session two questions are a little bit lengthy and the more of applied aspects and the more demanding your basic understanding of the concepts. That's what we used to say from the beginning itself. If your concepts are very thorough, you can crack any exam and you can excel in any exam. So that is the learning. And don't worry, you're given it, so it's time for relaxation. So let's see how the results come. Definitely it will come in your favor only. So let me wish you all to see in your dream seat in your dream institution. So we'll start the recall now. So if you ask me, actually I collected around 66 questions from pathology from both the sessions. Yes, it is 66 questions. If you calculate, like it is almost 33 questions per paper. That is one-sixth of the paper, the weightage actually. If you do pathology knowledge, you can answer this one-sixth of the paper. That is a stress I want to emphasize on the basic of understanding this basic concepts in pathology. So let's see, and I'm also happy to share that almost everything actually came from our workbook only. So I can also show you the references. So let's see the questions quickly. So the first question is, a 40-year-old female with presented with thyroid swelling and a malignancy was suspected. And thyroidectomy was done, and the histopathological findings, good morning, and the histopathological findings of the mass is shown below. Which of the following genes is responsible for her condition? Yes, as you can see from here that every time there is a question from thyroid carcinoma will be coming, and most of the time they'll be asking papillary carcinoma followed by this medullary carcinoma. This time also they've asked about this papillary carcinoma. Yes, with the thyroid swelling, and you can see this classical papillary projections and the typical orphan eye nucleus. We made a diagnosis of the papillary carcinoma of thyroid, that is quite evident, and also the most common the mutation, the gene mutation responsible for this is this BRAF mutation. Yes, BRAF mutation. So papillary thyroid carcinoma, BRAF mutation, we have stressed many times. So you can see here that typical this orphan eyed nucleus is there. And also you can see this BRAF mutation. Also we will recollect that hairy cell leukemia, Langerhans histiocytosis, papillary carcinoma, thyroid, pilocytic astrocytoma. So colonic cancer and melanoma are the other places where you can get this BRAF mutation, which is a potential for the upcoming exams. Yes. So upcoming exam, these are the potential areas. The next question is, a 40-year-old male recently underwent a gastrectomy. He needs supplement with which of the following vitamin? Yeah. So this is the again a classical question. So gastrectomy. So as we all know that gastrectomy, the gastric parietal cells producing the intrinsic factor, which is responsible for the vitamin B12 absorption. So gastrectomy, as you can see here from our notes, the gastrectomy predisposes to vitamin B12 deficiency because intrinsic factor is not there, B12 is not absorbed. So we have to supplement it with this vitamin B12 in a patient who undergone this gastrectomy. You can see from our notes also this thing. The third question, a 25-year-old patient with a known history of thalassemia presents with the sudden onset of severe anemia and is diagnosed with an aplastic crisis. Which of the following viruses is most likely responsible for attacking the erythroid progenitor cells and causing this condition? Yes, as you can see here, This the history of thalassemia, that is a patient with a known history of hemolytic anemia, and suddenly he is presenting with a severe anemia and he is presenting with aplastic crisis. So particularly this is responsible attacking for this virus is attacking the progenitor cells, and obviously this is the parvovirus B19. So the classical answer here is the parvovirus B19. So as you can see here from our thing, parvovirus causes this fifth disease or erythematosus, and this is the one which causes aplastic crisis not only in sickle cell anemia but also in our thalassemia also. And these are all the one of the infectious cause of the aplastic anemia. Please note down. Also, this can be a potential future question. Hepatitis infection is the most common infectious cause of aplastic anemia. Aplastic anemia. The next question, moving to the fourth question. A 6-year-old child presents with chronic diarrhea and itchy skin lesions. Itchy skin lesions, the lesions are erythematous, vesicular, and primarily actually located on the extensor surfaces. The child is asked to follow a gluten-free diet. What is the most likely etiology of this condition? Yes, so the one of the classical history is that chronic diarrhea, and also the child is advised to follow a gluten-free diet. The most likely etiology of this condition is actually is it is the celiac disease, because this is a gluten-sensitive enteropathy. The itchy skin lesions can be of this dermatitis herpetiformis, which is associated with the celiac disease. But the main thing is here is the chronic diarrhea and the gluten-free diet. They are mainly asking the focusing on the GI aspects. So here the most likely diagnosis is that celiac disease. Dermatitis herpetiformis is the association with celiac disease. So you can see here, this celiac disease, that is a gluten-sensitive enteropathy, and will be presenting with this total villus atrophy. You can see here that all the villi are totally they are atrophied. So this is presenting with total villus atrophy. The next question is also actually the another session they have asked is every morning session one question on celiac disease, even the evening session also they've asked with the celiac disease. So it's more sort of like they try to neutralize the thing, but don't worry, definitely normalization will be done. So it's nothing to worry about. These people will do. Everybody has done well. Like let's hope for the best. So a 10-year-old child presenting with a chronic diarrhea, weight loss, and abdominal distension. The child is suspected to have celiac disease. Yes. So they have asked which antibodies is most likely to be elevated in this condition. So is it anti-nuclear antibody or anti-mitochondrial or anti-tissue transglutaminase antibody? So this is the classical question. TTG, anti-TTG, which is the most sensitive and the most specific antibody in the celiac disease. Anti-endomysial antibodies are also present in the celiac disease, but the most sensitive as well as the most specific antibody to be diagnostic of the celiac disease is this anti-tissue transglutaminase. Yes, so the history also supports this and diagnosis also the celiac disease. Yes. Okay, okay. So in both the sessions, it was the in the morning session itself, it was the celiac disease. Okay. Then this is the other question. Identify the chromosomal pattern or what is being seen in the image below. So this is a question on the genomic imprinting, and actually this is the 15th chromosome, 15th chromosome. And most of you said that the deletion part, they have said that a particular part of the paternal chromosome was deleted. Paternal chromosome was deleted. So as we know from our things, genomic imprinting, a part of the chromosome is getting silenced. And imprinting actually says that how we will remember maternal deletion, maternal angels, maternal mothers or angels. So maternal deletion, it is, yes, Angelman syndrome, and paternal deletion, it is Prader-Willi syndrome. Prader-Willi syndrome. So the chromosome paternal is getting deleted. So the answer here is the Prader-Willi syndrome. Yes. So you can see here from this thing, and also please remember the future questions. So the Prader-Willi syndrome, the deleted gene is SNP gene, and the maternal gene deletion in Angelman syndrome, the gene deleted is UBE 3A. So these can be the potential future questions for the other students who are listening these things. And a question on the karyotype, and a 23-year-old phenotypically female with the short stature and amenorrhea, short stature and amenorrhea. A karyotype analysis, the karyotype, as you can see here, a typical karyotype of 45X0 was given. X0 was given. So this X is typically of X0. This is characteristic of the Turner syndrome, 45X0. And also you could remember that whatever the things we discussed in our classes, we have discussed Turner's, Klinefelter, Downs, Patou, Edward. So this can be the future questions. So they can put the karyotype of any of these disorders and they can ask you what is the diagnosis. So understanding this karyotyping, as I used to insist, is one of the most important in identifying the genetic disorders. So this is 45XO pattern. This is Turner's syndrome. The next question, a 32-year-old female with a fatigue and a pallor. So they have diagnosed, they have given the lab values and they have given the normal values also. I was told that. So the hemoglobin is reduced and the serum iron is also reduced. Ferritin is also reduced. The transferrin saturation. So everything is reduced, but the total iron binding capacity. So the total iron binding capacity is increased. The total iron binding capacity is increased. So this is very characteristic. All the parameters are reduced, but the total iron binding capacity, it is increased. It is diagnostic of the iron deficiency anemia. It is a diagnostic of the iron deficiency anemia. Yes, total iron binding capacity is increased. So with this, we'll conclude because lot of I heard that this exam actually they asked more questions in the iron deficiency anemia. Some 2 to 3 questions involved with the iron metabolism and lab values in iron deficiency anemia they've asked. So every year there will be at least 2 or 3 questions. I used to say the microcytic hypochromic anemia. Either they will ask you to differentiate between iron deficiency anemia or anemia of chronic disease, or pertaining to iron deficiency anemia or thalassemia minor and iron deficiency anemia. Use of this Menzer index. Menzer index to differentiate between this thalassemia minor and iron deficiency. I mean, these are all like evergreen areas. Every year they used to keep on asking the questions. You can see here, this same typical tabular column would have helped you to solve this MCQ. A 40-year-old male is diagnosed with the ARDS, acute respiratory distress syndrome, and the patient is not responding to the oxygen therapy. So they have asked mainly the role of the interleukin-8 in the pathogenesis of ARDS. So interleukin-8 mainly, actually, it is mainly the initiating event is the endothelial injury and this activation of the neutrophils. So this activation of the neutrophils is mainly by the interleukins. Yes, so interleukins actually mainly help in the mobilization, recruitment and activation of the neutrophils. So this neutrophils only will be releasing further many cytokines which only damage this endothelium further and will be releasing in the vascular damage and deposition of the hyaline membrane around the alveoli. So the most important initiating event here is this interleukin 8, which is recruiting the neutrophils and activating it. You can see here the next question. A 55-year-old male presented with hematuria, flank pain, and a palpable mass in the left kidney. So imaging, actually, these are all the bits and pieces of information that I got from the recall aspect based from the students and put it like in the form of the question. So the biopsy, I heard this biopsy, they have given this histopathological image of this typical appearance. So as you can see here, the shrunken nucleus with a perinuclear halo, with a perinuclear halo. You can see here this appearance, as you could see from our notes. So this chromophobe appearance, the nucleus with this typical halo, this is the typical plant cell appearance. So this plant cell appearance is characteristic of this chromophobe renal cell carcinoma. So the typical, and also I was told that there was a gross image given in this question. So it's chromophobe, more of brownish in color and like oncocytoma, and you can see this typical plant cell appearance seen in this chromophobe renal cell carcinoma. The next question is like every exam. So last exam they stopped, but again it will be keep on repeating everyone's alternate exam. That is a Gaucher's disease. So the child presenting with this organomegaly, easy bruising and bone pain, and the bone marrow aspirate showing this typical Gaucher's cells. Yes, the typical Gaucher cells with this crumpled tissue paper appearance. Yes, the crumpled tissue paper appearance. This time they have asked about the constituent. What is the scene? What is the enzyme deficient? So the enzyme deficient here is the glucocerebrosidase, and the enzyme deficient is glucocerebrosidase, and the substance which is accumulated is the glucocerebrosides. Also, the potential question you can remember from our notes: the pseudo-Gaucher cells can be seen in or sea blue histiocytes, which is a potential future question, can be seen in CML, myeloma, and thalassemia, and this Hodgkin's disease. And remember, Gaucher's disease is the most common lysosomal storage disorder. The next question, 65-year-old male presents with a hepatosplenomegaly, fatigue, and bone pain, and the bone marrow biopsy showing the typical 22% plasma cells. So the count of the plasma cells has increased, and the histology actually in the biopsy they have showed this typical acellular eosinophilic material. Yes, you can appreciate here this homogeneous, uniform, homogeneous acellular eosinophilic material is characteristic of this, the typical description of the amyloid. Yes, so 22% plasma cells and also this bone pain confirms you fatigue tells you that the patient is having anemia. So anemia, bone pain, plasma cells increased, so the CRAP symptoms are also there, and also the plasma cells are also elevated. So this is a typical case of multiple myeloma associated with this amyloid deposits. So this is amyloid deposits. And guys, do you remember what type of amyloid it is getting deposited? Yes, you can see from our notes that multiple myeloma, that is in the primary amyloidosis, the amyloid deposited is the AL amyloid, which is the light chain. Yes. Coming to the next question, a 5-year-old child presents with the severe skin eruptions and blistering after minimal exposure to the sunlight. The child also exhibits freckling in the sun-exposed areas and corneal opacification. The diagnosis is a genetic defect. They have given a clue that it is a defect in the DNA repair. And what is the basic defect underlying this condition? As you can see here, the child, 5-year-old child, even after minimal exposure to the sunlight, actually he exhibits this freckling and also the corneal opacification. So there is a defect in the DNA repair. So this is nothing but the xeroderma pigmentosa, in which there is a defect in the nucleotide excision repair defect. Remember my saying, xeroderma X. So xeroderma X, xeroderma pigmentosum, nucleotide excision repair defect. Yes, so remember like this. So the same exactly they are asked this. So nucleotide excision repair, xeroderma pigmentosa, there is an increased risk of skin cancer. And next question, moving on to the next question. A 28-year-old female presents with complaints of dysuria and lower abdominal discomfort. She also reports a history of multiple painful genital ulcers, and the pap smear image, I was told that a pap smear image with this multinucleated giant cells. As you can see this, we used to insist to remember 3 M's. Yes, so you can see here the multinucleation. There are multiple nucleuses, there multiple nucleation. Then what else? Molding, the nuclear molding, and also you can see the margination of the chromatin. The nuclear material, the chromatin nuclear material is marginated to the tip of the edge of the nucleus. So the 3 M's: nuclear multinucleation, molding, and the margination. If it is there, it is characteristic of this herpes virus. It is characteristic of this herpes virus. Okay, so you can see here this typical typical of herpes. So cytomegalovirus will have this owl's eye-like appearance with a perinuclear halo, but this 3M, especially in the pap smear, you will be thinking of this herpes simplex virus. The next question is, a 45-year-old woman presents with progressive muscle weakness, and particularly in the eyes and face, which worsens with activity and improves with rest, or is the directly they have given the myasthenia gravis, or like a typical of this history they have given? I'm not sure, because many students are given equal type of responses. So anyhow, this is a case of myasthenia gravis, and the patient actually also had this ptosis and fatigable muscle weakness. So they are asking this patient presenting with the anterior mediastinal mass, what is the likely diagnosis? Yes. So myasthenia gravis and with the anterior mediastinal mass, obviously you'll be thinking of this thymoma only. Thymoma only. Remember this from our paraneoplastic syndrome, the table column which we discussed. So myasthenia gravis is associated with this thymic neoplasm. Also remember thymoma, pure cell aplasia. Thymoma, you can also remember this pure cell aplasia. See this. So this can be a future question. So that pure cell aplasia can be associated with this thymic neoplasms. Moving on to the next question. A 20-year-old male presented with a history of recurrent episodes of meningitis and septicemia, and laboratory testing reveals a deficiency in the membrane attack complex of the complement system. So they're asked about the deficiency of a membrane attack complex, MAC. So MAC is nothing but C5 to C9, complement protein C5 to C9. So in their deficiency predisposes to what? That was the type of question I think they have asked. So the answer here is the recurrent infections with the Neisseria species, because this membrane attack complex will form a pore. They attack the membrane and will cause the lysis of this bacteria. And also, please remember from our notes, the other bacteria which can be predisposed in this MAC deficiency is Neisseria, pneumococci, toxoplasmosis. So all the other agents which can be predisposed in this membrane attack complex deficiency. Moving on to the next question, 17th question. A 35-year-old female presented with reduced hemoglobin and platelet count, and PT-APTT was prolonged. So this is a sort of hemoglobin reduced, platelet count reduced, and PT-APTT prolonged. So this was a case of a disseminated intravascular coagulation. And in the peripheral smear, you can see this, the typical blast, the myeloblast. What is seen in this myeloblast? You can see this myeloblast will be having this typical oil rods. You can see this, the multiple oil rods, the cells are called as phagot cells. Yes, we collect those points. So these phagot cells are actually characteristic of this APML, that is acute promyelocytic leukemia. Remember my mnemonic, APML, AML M3. Remember the three-letter complication DIC. Yes, so DIC, AML M3 you will remember, and the fusion gene which is seen in this AML M3 is PML RARA mutation, PML RARA fusion gene. Yes, as you can see here, these are all the typical phagot cells we have discussed. And also remember this AML M3, that is the translocation 15 and 17. Yes, you can see from our notes, it is PML RARA, that is PML in the 15 and RARA in the 17. So there is a high incidence of DIC. Also remember ATRA, that is all-trans retinoic acid, is the treatment for this AML M3. It responds very fast. Good response will be to this ATRA. Moving on to the 18th question. A 32-year-old professional football player suddenly collapses during a match and is brought to the emergency department in cardiac arrest. Resuscitation efforts are unsuccessful and the patient is pronounced dead. That is a sudden cardiac death in a young athlete or a football player, basketball player. That itself will give you a diagnosis. And also, in addition, they have given this histopathological image. Typically, that is the helter-skelter deformity. Yes, so this is the typical helter-skelter deformity we discussed in our notes. That is the haphazardly arranged cardiac fibers. Haphazardly arranged cardiac fibers. That is a helter-skelter deformity. These findings will typically get you to a diagnosis that it is hypertrophic obstructive cardiomyopathy. Hypertrophic obstructive cardiomyopathy. As you can see here, the most common cause of cardiomyopathy is dilated, and the most common risk of sudden death in young athletes is this hypertrophic cardiomyopathy. Yes. So moving on to the 19th question. An 18-year-old male presented with hepatosplenomegaly, abdominal pain, fever, and a WBC count greater than 50,000. Platelet count is less than 20,000. Which of the following chromosomal translocation is most likely involved in this condition? Actually, I was told that some people told that they initially gave this as a Philadelphia chromosome and they asked about the translocation. And some told it was the translocation only was asked. So I framed the question like this. So there's with the organomegaly and a fever and WBC count and platelet count 20,000 reduced. So with a chromosomal translocation, so it is a CML case. So Philadelphia chromosome, ABL, BCR translocation. So the translocation is 922. The translocation is 922. 922. See here, the ABL oncogene, BCR, that is actually, which is the Philadelphia chromosome actually. It is the 22nd chromosome is the Philadelphia chromosome because the ABL gene is fused to the BCR gene and activating the tyrosine kinase. So the actual Philadelphia chromosome is that chromosome number 22. Moving on to the 20th question, that is something like an out of box question. Again, they're given the box appearance. So a 40-year-old female presents with a localized hard thickened skin on her forearm. The skin biopsy is performed and the image is showing this typical square and box appearance. So this is very typical. So see this is the typical square. The biopsy itself will be coming like a, when they take this biopsy, the biopsy itself will be coming like a square and box appearance. And this is characteristic of morphia. Morphia is nothing but it is the localized form of the scleroderma. Systemic sclerosis is generalized and morphia it is the localized form. Yes, morphia you will get this square and box appearance. The next question, 21st question is the 53-year-old man with a 4-month history of progressively enlarging painless nodules on his scalp and perianal region. He had undergone, there was a history of people told that history of liver and kidney transplantation 2 years ago. So there was a transplantation and the patient was receiving all the immunosuppressants, tacrolimus, mycophenolate mofetil, and prednisolone for the immunosuppression. So there was a history of immunosuppression and the scalp lesions actually quite unusual, but definitely can occur. So this and the histology showing this typical Michaelis-Guttman bodies. Yes, where you hear this Michaelis-Guttman bodies. Yes, the Michaelis-Guttman bodies are typically actually seen in the malakoplakia, which is actually a defect in the phagocyte function. I agree this malakoplakia is common in the bladder, urinary bladder, but definitely can be seen in other organs also. So if you could identify this malakoplakia and definitely this Michaelis-Guttman bodies, then malakoplakia will be definitely a good option. So malakoplakia is the correct answer. Correct answer. A 60-year-old male with a history of MI was found deceased at home. An autopsy was performed and the histological examination of the heart shows extensive necrosis with a brisk infiltration of the neutrophils. Based on the histopathological findings, what is the most likely timeline of this since the infarction? So this histopathology showed a typical of this thing, this myocardial muscle, which is characterized by lot of infiltration by the neutrophils. So the timeline actually, if it is less than 1 day, neutrophils will be there. Neutrophils infiltration will be just starting at the within 1 day. The coagulating necrosis will be more prominent and more predominant there. But the neutrophils will be just started, early infiltration of the neutrophils. But when the word actually, you can see lot of neutrophils, when there is lot of neutrophils infiltrating this, you will be seeing this brisk infiltration only. And this is actually typically seen in the 1 to 3 days after MI. 1 to 3 days after MI. So the neutrophilic infiltration will be most commonly seen in this 1 to 3 days after the MI. And the 24th question is the pedigree chart actually is shown and which of the following is the most likely represented in the pedigree. So as you can see in this chart, the females are the carriers. Yes, the females are carriers and the males are affected. So females are carriers and the males are affected. So the typical pattern of inheritance is this X-linked recessive disorder. So in which females are the carriers and the males are the affected. So out of all this thing, achondroplasia, Achondroplasia is actually autosomal dominant, and so I'm not sure this hemophilia was not given. So I hope so. And hereditary spherocytosis is autosomal dominant. So out of this, the options as per your things, they've given the option as Wiskott-Aldrich syndrome. Wiskott-Aldrich syndrome. So Wiskott-Aldrich syndrome, which is a triad of thrombocytopenia, infarction, repeated infarction, and eczema. The pattern of inheritance is X-linked recessive. X-linked recessive. So with this pedigree chart, the diagnosis is this X-linked recessive Wiskott-Aldrich syndrome. I hope hemophilia was not given in the options. The next question, a 45-year-old male presented with a loss of weight, paresthesia, and numbness in the legs with the polyuria. A bone marrow aspirate was done, and the finding actually they have given the image. So the patient presenting with the weight loss and neurological manifestation, numbness in the lung, and also you will be thinking of vitamin B12 deficiency. But please see here there is also a history of polyuria, which is quite unusual there. So polyuria actually will be more pointing towards you that towards a case of renal dysfunction, and also this cell cannot be mistaken for any other cells. That is, these cells are typical of this MOT cells. Yes, these, as you can see here, these are the typical MOT cells, the grape cells. MOT cells are the grape cells, which are the cytoplasmic inclusions. So the this with this MOT cells, the diagnosis of multiple myeloma can be made, and the polyuria also suggests that this is a renal failure. And obviously, the other options, I was told that the other options can be easily, they can rule out based upon the clinical history and the image findings. Moving on to the 26th question, a 28-year-old male patient presents with respiratory distress, chronic cough, and a progressive shortness of the breath. He has a history of early onset of emphysema, and the imaging studies confirms the presence of pan-acinar emphysema. So as you can see here, the pan-acinar emphysema is common in the lower lobes of the lungs. So they have asked about what is the enzyme deficiency responsible for this condition. So pan-acinar emphysema, when all the lobule is getting acinar is getting affected. So the enzyme deficient is the alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin deficiency. As you can see here, the pan-acinar emphysema, it mainly affects the lower zones, and it is the alpha-1 antitrypsin deficiency. Moving on to the next question, the 27th question they have asked about, which is not true about this PNH, that is a paroxysmal nocturnal hemoglobinuria. So close lysis test is confirmatory, flow cytometry is a gold standard investigation, and it is an inherited disorder. Most common cause of death is cardiac failure. These are all the options. So actually, it is not an inherited disorder. It is a it is an acquired disorder. PNH is an acquired disorder, and the most common cause of death is not a cardiac failure. It is because of the thrombotic related events, and definitely suppose lysis test is not confirmatory, and flow cytometry is the gold standard investigation, in which that is a flat test. Yes, in which you will be demonstrating the absence of CD 55 and 59. Yes, you remember that CD 55 and 59 you demonstrate by flow cytometry. That is, absence of antigens can be demonstrated by the flow cytometry only. No, so that is actually true about this PNH, paroxysmal nocturnal hemoglobinuria. As you can see here, this gold standard test is, we have mentioned that flow cytometry, absence of CD 55 and 59. 55 and 59. 45, moving on to the 28th question. A 45-year-old patient presents with a headache, palpitations, hypertension, and episodes of flushing and sweating. And the word retroperitoneal tumor was highlighted, and the tumor marker, that is the elevated levels of vanillyl mandelic acid, was mentioned. So they have asked about what is the correct statement about this condition. So the typical history of a headache, palpitation, hypertension, flushing and sweating, so hypertension, palpitation, flushing and sweating, and VMA tumor marker. So this is nothing but this is our tumor, that is the pheochromocytoma. As you can see from our discussion, this is the tumor of 10%. Yes, guys, you remember it is a tumor of 10%. That is 10% are bilateral, 10% are extraadrenal, 10% are malignant, 10% are children, and 10% will have calcification. And remember, I told about the recent update in the Robbins, that is, it is no longer 10% familial, it is 25% familial. That can be a future potential question. Yes, with this, I can show you this history of headache, hypertension, headache, and palpitation, the typical history. So it is not mostly malignant, only 10% is actually the malignant. Only 10% are seen in the children, only 10% are bilateral. Yes, pheochromocytoma is associated with this. Men 2A. Yes, pheochromocytoma, parathyroidism, and medullary carcinoma thyroid are the components of the men 2A syndrome. Yes. We can see this typical the next questions, the next future question, that is the Zellbalan pattern can be asked, and the sustentacular cells in this pheochromocytoma are positive for this S100, and also the tumor cells in pheochromocytoma, remember it is positive for synaptophysin and chromogranin. This is for the future aspirants who are watching this video. A 40-year-old patient with a history of asthma presented with wheezing and respiratory distress after taking aspirin. So, asthma plus aspirin will bring to the, and also the patient is having the nasal polyps. So, this brings us to the classical triad, that is the Samter's triad with the asthma, nasal polyp, and aspirin, what we have discussed. So, they have asked this, what is not true about this condition. So actually, what is this Samter's triad is because this aspirin is inhibiting the cyclooxygenase. So aspirin, you can see this aspirin is inhibiting the cyclooxygenase. So these prostaglandins are not formed. So actually, it is the lipoxygenase which is diverted. So the synthesis is more towards the mediators towards the lipoxygenase. So more leukotrienes are produced. So the symptoms are mainly because of the increased leukotrienes. Yes. So this is correct. Leukotrienes. So all the leukotrienes are produced here, which will cause this bronchospasm and aggravating all these things. So leukotrienes plays a major role in the key role in the symptom development. Yes, obviously, COX inhibition by aspirin triggers the condition, and definitely a leukotriene antagonist like montelukast can help in the managing the symptom. But it is not a hypersensitivity reaction. Yes, so this is not a type of hypersensitivity reaction, so which can be easily picked up here. So it is not the samtosteroid is not because of the hypersensitivity reaction. Yes, moving on to the 30th question. An elderly male presented with the symptoms of hypercalcemia, renal failure, anemia, and bone pain. That is the typical CRAP symptoms of the. And also, in addition, the patient had this multiple lytic bony lesions. So, electrophoresis, I was told that M spike band was increased, M spike was increased. And as you can see here, the immunofixation image, the IgG. There was actually confusion between the students. Some were saying that IgG was elevated, some were saying that IgEM, there was a dark band. So, but most students, majority told that IgG was a strong only mark. And also you can see this kappa chain restriction. Remember, light chain restriction is a feature of this multiple myeloma. So it is nothing but multiple myeloma with increased IgG, multiple myeloma because of the symptoms, and it is the IgG because of the dense markings in the IgG. Okay, so it is a monoclonal proliferation. And moving on to the 31st question. A 45-year-old male presented with a hemoptysis and shortness of the breath, and pulmonary involvement was there. So, pulmonary involvement was there with a pulmonary hemorrhage, and the patient had a history of positive with a P anchor. So, they have also given the clue in the stem that actually it is a posse-immune word was mentioned, and also that it can be a sort of a small to medium sized vasculitis. So small to medium vessel vasculitis with the P anchor positivity, actually there are two things. Mainly there's a Church-Strauss syndrome as well as this microscopic polyangiitis. I hope Church-Strauss syndrome was not there in the option. Yes, it was not told by the student. So the typical option presenting here with the microscopic polyangiitis. Also, please remember the differentiating point with the polyarteritis nodosa and microscopic polyangiitis. Polyarteritis nodosa is anchor negative, and also pulmonary involvement will not be seen. But the microscopic polyangiitis, typically there is a pulmonary infiltrate will be there, hemorrhage will be there, and also P anchor will be positive here. Yes, the typical everything we have discussed about this microscopic polyangiitis in our workbook. Moving on to the 32nd question. A 30-year-old woman presented with progressive fatigue and unintentional weight loss, night sweats over the past few months, and the lymph nodes were enlarged, palpable in the cervical and supraclavicular lymph node region. And they have asked this, given this typical image of this means this typical owl's eye-like appearance, that is the RS cells, Reed Sternberg cells. So this is a case of the Hodgkin lymphoma, and the typical Hodgkin lymphoma is the diagnosis, and it is easy to choose this ABVD regimen, which is commonly used for the newly diagnosed cases of Hodgkin's lymphoma. So Reed Sternberg cells, definitely no one should forget about this Reed Sternberg cells, which is classical of this Hodgkin lymphoma. Moving on to the 33rd question. A 35-year-old female presents with fatigue, pallor, and shortness of breath on exertion. She reports heavy menstrual periods over the past several months, and the hemoglobin was reduced. Hemoglobin was reduced, and microcytic hypochromic red cells were seen on the peripheral smear. And they have given this is a typical another question on iron deficiency anemia with a serum ferritin level of 8 nanogram, with a serum ferritin level of 8 nanogram per ml. So what is that they asked about what will happen to the transferrin saturation in this patient? So obviously we know that the iron deficiency anemia. So iron itself is deficient. Iron itself is deficient. So the transferrin saturation in iron deficiency anemia is decreased. The transferrin saturation in iron deficiency anemia is decreased. Okay. So please see here the transferrin saturation we have mentioned in iron deficiency anemia, it is decreased. So this is a vital table which will be helpful to solve you many number of questions. Yes, every exam they keep on asking these questions on this about the parameters in the iron deficiency anemia. Moving on to the 34th question. A 2-year-old child presented with recurrent infections and a failure to thrive, and there was a mediastinal imaging reveals the absence of the thymus gland. Yes, absence of thymus gland. Among the given options, you will be thinking of DiGeorge syndrome and severe combined immunodeficiency. But the next important clue that is very picking up the diagnosis, that is, this patient has significantly reduced adenosine deaminase deficiency. Yes, so the ADA levels are markedly reduced. Yes, as you can see from our workbook, this typical description, that is the adenosine deaminase deficiency is characteristic of this autosomal recessive variant of this severe combined immunodeficiency syndrome. There are two variants, as you know, SCID. One is autosomal recessive and the other one is X-linked recessive. So adenosine deaminase. So adenosine deaminase is deficient in this severe combined immunodeficiency syndrome. That is picking up the clue rather than the for SCID rather than DiGeorge syndrome. Okay. Moving on to the 35th question. A 75-year-old woman presents with progressive memory loss, disorientation, and difficulty with the language over the past 2 years. Family reports that she forgets the names of close relatives and struggles with basic tasks. So this is actually a typical history of what I suppose that typical history of Alzheimer's disease was given. And they have given even the MRI findings with the cortical atrophy, and which is the likely marker deposited associated with her condition. Yes, as you can see here, many times we have discussed. So this Alzheimer's disease, actually we have two proteins. One is beta amyloid, the two characteristic lesions. One is this tau proteins. Remember this tau proteins, which is nothing but seen in the tangles, microtubule protein. The other one is this neurotic plaques, which is nothing but a characteristic deposition of this A beta amyloid. A beta amyloid. Okay, remember this Alzheimer's disease. Okay, so Lewy bodies, alpha-synuclein, and TDP-43 are seen in other this frontotemporal dementia or the Lewy disease or all such thing, not in the Alzheimer's disease. So this is also a classical question. Moving to the next question, a 28-year-old male presented with a history of tall stature and arm span that exceeds its height, subluxation of the lens and the pectus excavatum. He also has a family history of cardiac abnormalities, including the aortic aneurysm. So they've given the history of long, slender fingers and joint hypermobility. So all were typical of this Marfan syndrome. So remember the point we used to stress, Marfan syndrome, we always remember the 15th chromosome and the associated defect, that is the fibrillin. Yes, so fibrillin 1. So the most defective protein in the Marfan syndrome is this fibrillin 1. Is fibrillin 1. Moving on to the next question is, this is also the classical question, repeat question, INI-CET NEET, that is the repeat question. That is a 65-year-old male smoker with a history of smoking, cough, weight loss, shortness of the breath. Imaging reveals a mass in the lung. And the very characteristic clue they have given is it is positive for the TTF1. Yes, the strong positivity for this. You can see even this glandular pattern here in this image itself. So this is a strong TTF1 positivity among the variants of the character of the lung cancer. The variant which is classically positive for this TTF1 is our adenocarcinoma of the lung. Adenocarcinoma of the lung. As you can see here, adeno A. Okay, that is the A alphabet. So you can see the napsin A positive and a TTF1 positive. So this is featured every time they'll ask about the markers for this adenocarcinoma lung, and sometimes they can ask with this squamous cell carcinoma, small cell carcinoma. They keep on repeating the things, but the topic wise, the repeat topics are the same. Yes. Moving to the next question. A 32-year-old male presented with a protruding abdomen, chronic diarrhea, progressive visual impairment, neurological symptoms, and ataxia and muscle weakness. So the distended abdomen, GI manifestation, and deep tendon reflexes, neurological manifestation. I also told that this laboratory investigation, they mentioned that LDL cholesterol was reduced and triglycerides also reduced. And also this typical peripheral smear findings, these cells. Yes, so these are all the spikes with irregular spikes. Remember, guys, regular spikes you will be thinking of echinocytes or Burr cells, but this irregular spikes you will be thinking of this acanthocytes or the Spur cells. So this acanthocytes and this classical characteristic history, you will be thinking of this A beta lipoproteinemia. A beta lipoproteinemia. Okay, so that was the answer which we typically discussed in our sessions workbook also, this A beta lipoproteinemia. Moving on to the next question, that is a 2-day-old male child presenting with a failure to pass meconium is diagnosed with this Hirschsprung disease, congenital absence of neurons absorbed between the which layers of the intestine. As you can see here, they have marked about the labeled the different layers of the intestine, and in our workbook, actually, we have discussed the same thing. See this? There are two nerve plexus which you have to remember. One is Meissner's nerve plexus, which is between the submucosa as well as the muscularis externa, that is the inner circular layer. Between the submucosa and the inner circular, you have Meissner's nerve plexus, whereas the Auerbach's nerve plexus is between the inner circular and outer longitudinal. Inner circular and outer longitudinal. But actually, in Hirschsprung disease, the lack of both Meissner's and Auerbach's nerve plexus. But luckily, I think the options they have not made us to confuse those things at all. So between the layers, actually, this submucosa and this thing, inner circular layer. So the nerve plexus between the submucosa and the inner nerve plexus, that is this Meissner's nerve plexus, actually is one of the thing. Even the nerve plexus, the Auerbach's nerve plexus is also absent, but it is between this uh, 3 and 4. That option was not there. Yes. So the correct answer is between this submucosa and the inner circular layer, which is between this 2 and 3. Moving on to the next question. Which of the following statements about the iron metabolism is true? So iron is completely excreted by gut, urine, and skin cells. That is the wrong option, because actually iron is not excreted by these modes and all. The body iron is recycled. Okay, so it is recycled, like a gut and skin cells are being shed and they are recycled, and it is not completely excreted by these mechanisms. And iron absorption, actually, this is iron is converted into ferric form by ferroreductase in the gut lumen. So, plus, as you can see here from our notes, this iron is getting converted into this ferric will be converted into ferrous form. Ferric is converted into ferrous form by this duodenal cytochrome B. Duodenal cytochrome B, and it is present inside the duodenal cells in the form of ferrous form only, not in the ferric form only. Ferric form. So this is also a wrong option. Iron absorption primarily occurs in the stomach. Acidity actually favors the iron absorption, but iron absorption is not occurring in the mainly occurring in the stomach. Instead, it occurs in the duodenum. So the correct option here is the iron is a transporter. Iron is transported in the blood, bound to the transferrin in the ferric form. Yes. So ferric, and it is transported and stored in the ferritin. That is the storage form. So it is in the Fe3 plus form only. It is being getting transported. As you can see here, once it comes out of the duodenal epithelial cells, ferrous is converted into ferric form. Yes. Okay. Now, the other typical classical question which we discussed in our class, again, it came. A 12-year-old child presented with a recurrent convulsion imaging reveals a heterogeneous cystic mass located in the supracellular region. And typically they have mentioned about this calcifications within the lesions and the typical machine oil appearance. Yes, the machine oil appearance. I was told that there was an image with a cystic lesion in the region also. So this is the one sort of image actually I picked up, and as you can see here, we have discussed this. Uh, all I told you the mnemonic CCC. Children, calcification, cystic tumor, cholesterol rich, this machinery oil fluid. The diagnosis is nothing other than this craniopharyngioma. Craniopharyngioma. So that machine oil appearance that will be the, and the cystic lesion will be the main clue for picking up this answer. And also remember future possible question, that is the wet keratin is seen in this craniopharyngioma. That is the lamellated keratin that is characteristic of this craniopharyngioma. A 25-year-old patient presented with the symptoms of acute meningitis with a fever, headache, neck stiffness, and altered mental status. A clinical team suspects like whether it is a bacterial or viral and seeks to quickly identify the causative pathogen agent. Yes. So, what is the cause of choice, investigation of choice in such case? Like when you want to identify like bacteria or virus, so multiple agents you want to identify at sort of a time. So, the ultimate diagnostic which comes for our rescue is this multiplex PCR. Yes. So PCR also we have touched upon in our classes. So you can remember this things we have discussed. Moving on to the 43rd question. A 55-year-old male presented with a 6-month history of dry cough and chest tightness. And there was a history of working in the industrial setting for the past 20 years and frequently exposed to the dust and these microparticles, inorganic particles. So there was a interstitial, diffuse interstitial lung changes also mentioned as per your recall. And the lung biopsy, histological lung biopsy features actually is characteristically will be shown. This image was given, this double shaped bodies, which was nothing but with the classical history of this industrial setting, that is the asbestos body. Yes, asbestos body. If there was a specific history of asbestosis, you have to think of asbestos body. And please remember, ferruginous body actually can be is characteristically asbestos body characteristically seen in asbestosis, but ferruginous body can be seen in asbestos, silicosis, or co-worker pneumoconiosis also. Okay, so the only the inorganic particle alone only changes in this ferruginous body. Yes, double-shaped body. And a very simple, like a jackpot question, that is, which modern laboratory test was largely replaced the traditional clotting time test for assessing the intrinsic pathway of coagulation. So previously the clotting test was used, and it is a simple question. Do you want to check the intrinsic pathway? What test you will use? Yes. So this is the basics actually we covered during our hematology session. So that is to check the intrinsic pathway, it is mainly the APTT, and to check the mainly the extrinsic pathway, it is the PT. Yes. So APTT measures about the activity of intrinsic plus the common pathway, and the PT, that is the prothrombin time, checks the integrity of this extrinsic as well as this common pathway. So the correct answer here is the for assessing the intrinsic pathway, it is the activated partial thromboplastin time. Moving on to the 45th question, a 14-year-old patient presented with neurological symptoms and a history of liver dysfunction. An ophthalmologic examination reveals the presence of KF rings, and this image I was told that you had this typical KF ring, confirming a diagnosis of this Wilson's disease. And the how will you estimate this copper overload? Actually, instead of this serum copper levels or urine copper levels and the serum ceruloplasmin, the hepatic dry weight. The dry weight of liver copper levels is the most effective, best method to confirm this diagnosis. As you can see from our notes, the gold standard test. The gold standard test, we have mentioned that hepatic copper estimation, that is more than 200 milligram of dry liver weight. We have mentioned clearly in our notes that it is the hepatic copper estimation is the characteristic of or the best method to confirm the diagnosis. Yes. Moving on to the next question. A 50-year-old male presented with a recurrent urinary tract infections and a history of kidney stones. The most recent analysis of his kidney stones reveals that they are composed of calcium phosphate. His medical history includes multiple infections with the Proteus, yes, and what type of kidney stones. Actually, the word highlighted, many of you highlighted the keyword which was highlighted in the seen in the questions is this Proteus species only, Proteus species. So Proteus infection, as you can see here, that it is a predisposes to this triple phosphate or the struvite calculi. Yes, so it is the nothing but the struvite or the staghorn calculi, the Proteus infection in the background of this urinary tract infection, struvite, that is a triple phosphate stone. What is a triple phosphate? Magnesium, ammonium, and calcium phosphate, staghorn calculi. Remember this. This exactly occupies this pelvic alicil system, pelvis of this renal kidney. So this struvite stones. Again, we discussed this. And another question, a 25-year-old male presented with recurrent kidney stones and flank pain, and they have shown the image of this hexagonal crystals, this typical six-sided crystals. So this is a typical image actually they have given in this exam, and this is characteristic. This hexagonal crystals are characteristic. These are nothing but cystine crystals, which are characteristic of cystinuria. As you can see here, we have discussed this. This cystine crystals. The cystine crystals or the crystals which is seen in the acidic urine, which are nothing but this benzene shaped ring. You can see this typical hexagonal shaped crystals are characteristic of this cystine. Last INI-CET they have asked about this triple phosphate crystals, and that is the typical of this coffin lid appearance. Coffin lid appearance. And remember this envelope shaped crystals, that is a calcium oxalate crystals. So these are the different types of crystals they keep on asking, repeating in different exams. So but this tabular column is very important. Another question, which is like sort of a new pattern they asked, is which stain is used to visualize the vocal cord lesions and assist in guiding the biopsy during laryngoscopy. So it is the AgNO3, AgNO3, which is the thing that silver nitrate, silver nitrate. This silver nitrate they will be applying on the suspicious lesions, like they will be applying the suspicious lesions, and they will be highlighting the counting, they are the nuclear, they will be counting this NOR. What is this NOR? NOR is nothing but nucleolar organizing regions. So if a cell has a high proliferative rate, if a cell has a high proliferative rate, the nucleoli will be more prominent, and they will be counting this, how much this nuclear organizing regions are there. By that we can see the proliferative activity of this lesion. And also the differentiation, whether for this, whether this can predispose to malignant, pre-malignant condition of this thing, this AgNO3 will be helping. Much of the information, actually after biopsy only this HNE staining and other stains will help, but during the biopsy, in guiding the biopsy, they have to guide no which area they have to take the biopsy. So this, for this, the silver nitrate stains will be helpful for you. And coming to the 49th question. A 45-year-old female presents with a palpable lobular mass in her breast. The mass has been slowly growing over the several months. She has a history of previous surgical resection of a similar breast mass few years ago. A mammogram reveals a large lobulated mass with smooth borders. Histopathological examination findings are shown below. What is the most likely diagnosis? So actually this was a, there was a case of previous surgical resection. There is a history of recurrence is also there. And they're saying that it is a large mass, large mass. And this histology, you remember from our workbook, the typical thing, a typical leaf-like protrusion. You can see the stroma. The stroma is protruding into the breast like a duct. It's like a leaf-like protrusion. This leaf-like protrusion is characteristic of this Phyllots tumor. Phyllots tumor. So the large mass leaf-like protrusion will be pointing out to the diagnosis of this Phyllots tumor. Moving to the 50th question. So a 45-year-old female presented with the painful vesicles and ulcers in the oral mucosa that persisted for several weeks. And she also had multiple erosions and a flaccid bulla on the oral mucosa. And the typical IgG image with this immunofluorescence image, that is this typical fishnet pattern appearance was given. And we know this typical fishnet pattern is characteristic of this Pemphigus vulgaris. Again, one more repeat topic is the question may be slightly different, but understanding the checking your most of your concepts, but the topics are from the high yield topics. As I used to stress, the high yield topics, if you are very thorough, you would have answered around some 160 questions correctly. Yes. keep your mind focused. When you would have kept your mind focused during the exam, definitely there is a chance that 150, 160 plus that range you could have covered it from the high yield topics. Yes, see here, we have discussed this fishnet appearance. 51st question, a child presented with leukocoria, that is a white reflex, and a mass in the retina, and the histology actually revealed the rosites. Yes, I was told that they have not given the image of this rosites, that is a flux nerve intestine rosites, but IHC markers they have given. The cells are positive for CD56 and chromogranin. Yes, this blastoma cells, retinoblastoma cells are positive for CD56 and chromogranin. And typically this in a child leukocoria white reflex, the answer is retinoblastoma. Retinoblastoma. Yes, see this? We have discussed this. And again, one question on this thing. A couple comes for diagnosis for genetic counseling regarding the hemophilia. The mother is a known carrier of hemophilia and the father is normal. The father family. Actually, some were saying that it is in the, they have not mentioned about the mother normal or father normal. They mentioned that it's in the family. Yes. So there basically there is a history of hemophilia in the in the mother, and father side that is totally normal. That means father is not a carrier or nothing is there. Mother is a carrier. So what are the possible outcomes? So mother is a carrier and father is also normal. Father is also normal. So how the pattern will be the, so the pattern will be, so this will be like this. This will be one type will be the, other type will be XX and XY. That is one out of the two daughters, one daughter will be a carrier and the other will be a normal daughter. One daughter, one son will be deceased and one son will be normal. So the correct answer here is half of the daughters will be carriers and half of the sons will be affected because father is normal. Father is normal and mother is a carrier. So this is the typical pedigree chart we have to remember as we discussed in our workbook. Yes. Moving on to the next question. So even actually students told that we could answer from this from our workbook, this sort of questions. A history of friends going to a camping adventure, eating improperly cooked hamburgers, and they were developing the symptoms of hemolytic uremic syndrome. So the suspected food poisoning in this case was asked, and this also we have discussed. The typical hemolytic uremic syndrome, it is the E. coli 0157 strains or the, that is the most typical ones causing this hemolytic uremic syndrome. That also we have discussed under this hemolytic uremic syndrome. Other one is Shigella dysentery. Yes. Remember this hemolytic uremic syndrome associated with this triad: MAHA, microangiopathy, hemolytic anemia, renal failure, and thrombocytopenia. Thrombocytopenia. Moving on to the 54th question. A 60-year-old man presents with a fatigue, pallor, and difficulty in walking. He reports feeling unsteady on his feet, particularly in the dark. On examination, he has a positive Romberg test. And the question asked was, he recently underwent an ileal resection. Ileal resection. So which of the following is not typically associated with this clinical presentation? So as you can see this, ileal resection predisposes to the vitamin B12 deficiency. Why? Because B12 is getting absorbed in the ilia. So the patient will be having megaloblastic anemia, neurological manifestation, obviously here it is there, and this, remember, nucleus synchrony, a cytoplasmic asynchrony, so only the cells are looking megaloblast, and definitely it is not associated with a microcytic hypochromic anemia. It is a megaloblastic anemia, macrocytic anemia. So please remember this point. Okay, so ileal resection we discussed. Ileal resection is a predisposing factor for this megaloblastic anemia. Moving on to the 55th question. A 5-year-old boy is brought to the clinic with the complaints of fatigue, easy bruising, and recurrent episodes of epistaxis. Is more of bleeding manifestation. And organomegaly is there. And what they have said is anemia, thrombocytopenia, and elevated WBC count. RBC reduced, platelets reduced, but the total count is increased. And bone marrow increased, bone marrow aspirate, they have showed this blast, and they have given the clue that this blast are positive for megakaryocytic markers. And I was told that they have asked about this karyotype which is associated with this. So please remember from our notes, this is a megakaryocytic markers. Blast with megakaryocytic markers is characteristic of this AML-M7. AML-M7. And what do you know about AML-M7? So AML-M7 is the acute leukemia, is the common cause of acute leukemia in the Down syndrome. Yes, AML-M7 variant is associated with the Down syndrome. Obviously, we all know that Down syndrome, it is the 47XY trisomy 21. So this will be the correct answer. So what you have to remember now, you have to remember this M7 with the Down syndrome. M7 with the Down syndrome. 56th question. A 35-year-old patient presented with the symptoms of cerebellar dysfunction, ataxia, difficulty in coordination, and a hemangioblastoma in the cerebellum. Hemangioblastoma in the cerebellum and renal mass consistent with renal cell carcinoma. There was also a family history of similar findings. So this is a cerebellar hemangioblastoma, renal cell carcinoma, family history. So this is typical of your von Hippel-Lindau syndrome. Remember guys, VHL gene. VHL chromosome number 3. Remember the 3-letter cancer, RCC, renal cell carcinoma. Okay, clear cell renal cell carcinoma, VHL gene. Yes, remember this. It is also associated with the cerebellar hemangioblastoma. Polycythemia can be a paraneoplastic syndrome because of the production of the erythropoietin. And another question about the statement asking which is not true about the von Willebrand's disease. So as you can see here, there are 3 types of von Willebrand disease in our, as per we discussed in our workbook. So type 1, it is a quantitative deficiency, partial deficiency. Type 3, it is a complete quantitative absent deficiency. So type 3 will be more severe than the type 1. Okay. And type 2, it is a qualitative disorder. Yes, moving on to this. Type 1 is characterized by mild to moderate quantitative deficiency of von Willebrand factor. This is right. Type 2 von Willebrand disease is associated with a qualitative defect. Yes, it is right. The number is normal, but the quality is abnormal in type 2. Type 3 von Willebrand disease most severe form because there is a complete absence of von Willebrand factor. This is also right. And type 2, it is not a complete absence. It is type 3. So this is the wrong option. Yes. Which of the following, next question, which of the following statements about the iron metabolism is not true? Not true. Yes. Is coming to the options from last. Serum ferritin is more convenient measure of iron stores. Yes, it is in the routine practice. Serum ferritin is the more convenient measure. Free iron is toxic. Iron is stored in the tissue in the form of ferritin and hemosiderin. This is also right. And but serum iron is measured, is bound to apoferritin. It is the wrong option. It is not bound to the apoferritin. It is the transferrin, and it is the storage form is the ferritin, and this is the wrong option. Yes. So this is also we have discussed. Moving on to the 59th question. A 7-year-old child presented with a generalized lymphadenopathy and a flow cytometry of the lymph node biopsy reveals the following immunophenotype. Actually, I was told that the CD19 positive, 10 positive, surface immunoglobulin positive, CD5 negative, and CD23 negative. Yes, and another important clue is TDT is negative. So TDT, we know that it is a marker of immaturity. So we are ruling out ALL. So it is a mature B cell neoplasm. And also note down, this is a child. This is a 7-year-old child. CD19 positive, 10 positive, surface immunoglobulin positive. So out of the other options here mentioned here, the best fitting here is the Burkitt's lymphoma. I was also told that some students told that there was given of an image of Burkitt's lymphoma slide with the typical cytoplasmic coagulations. The atypical cells with this typical cytoplasmic coagulations was given, I was told. So this is a case of Burkitt's lymphoma. So we can see the CD10 is also positive here. Okay, so we can see here CD10 positive and surface immunoglobulins are positive in this Burkitt's lymphoma. We have discussed in our workbook. So the answer here is the Burkitt's lymphoma. Burkitt's lymphoma. Moving on to the 60th question. A 4-year-old child presented with multiple scalp lesions and rash. Imaging reveals lytic lesions in the calvareal bones. The skin involvement includes a scaly rash on the trunk and the scalp. Based on these findings, what is the most likely diagnosis? Yes, this is a typical thing of this Langerhans cell histiocytosis. Yes, the lytic lesions in the bone and the scalp lesions in a child. Please, and also the skin lesions characteristic of this LCH. And please remember the future questions that eosinophilic granuloma lateral severe disease and Hanschler-Christian disease. This is also one important PYQ, that is a Hanschler-Christian disease presents with the triad of multiple bony lesions, exophthalmos, and diabetes insipidus. Diabetes insipidus. Moving on to the 61st question. A 15-year-old male presented with a localized pain and a swelling in the mid-femur. Imaging restrictive lesion in the periosteal reaction, that onion skin appearance. And a biopsy of the lesion was done and the image is shown. And this is the typical translocation 1122 translocation. The image of this Ewing sarcoma, that is the typical small blue round cell tumor with glycogens present in the cytoplasm, and they show these cells are also positive for PAS. And this typical translocation 1122 tells you that this is a Ewing sarcoma onion skin appearance, confirms that, and it is easy to pick this EWS Ewings. So Ewings FL FLI1. So this is the typical gene fusion present in this Ewing sarcoma. As you can see here from our workbook, we have discussed this. And these tumor cells are also positive for this CD99. Moving on to the 62nd question. A 50-year-old male presented with a sudden onset of severe chest pain radiating to the back. He has a history of hypertension. Imaging reveals a dissecting aortic aneurysm. And I was told this is sort of a typical thing. It is the blood column which is piercing the tunica media. You can see this. This is the tunica media, that is the muscle, smooth muscle layer. And this column of the blood is piercing the tunica media, So this tunica media, when it is pierced by this column of blood, that means it is a weak. So what are all the causes of aortic dissection, as we have learned, right? Hypertension is the most common cause, and the other causes are this connective tissue disorders, Marfan syndrome, Ehlers-Danlos syndrome. So this thing, and also this connective tissue disorders also predisposed to a weaker tunica media. That is the cystic medial necrosis. Cystic medial necrosis occurs in this Marfan syndrome. So upon this, there is connective tissue disease is the most appropriate option, because please remember atherosclerosis dissection never occurs, because actually atherosclerosis actually it is a fibrosis. So the dissection doesn't occur there. And fibrinoid necrosis, it is associated with the vasculitis, and granulomatous inflammation will not fit in here. So the option here is a connective tissue disease. Moving on to the 63rd question. Which of the following set of the tumor markers is the most appropriate for the diagnosis and monitoring of the epithelial ovarian cancers? And there was a sort of a different sets of these tumor markers are given here. So, and as you can see from our workbook, actually this is the typical ovarian cancer will have the CA125, which is also present in all the other options. So the correct option here is this CA125, CA19.9, CEA. So this set of the list, actually that is the main markers present here. Moving on to the 64th question. A 28-year-old patient woman presents with this chronic pelvic pain and dysmenorrhea. She has a history of infertility and reports worsening pain during menstruation. On pelvic examination, a tender adnexal mass is palpated. An ultrasound reveals a cystic ovarian mass, and laparoscopic is performed, and the cyst is drained, revealing thick dark brown fluid. What is the most likely diagnosis? So as you can see here, this is the endometriosis, that is the chocolate cyst of the ovary. I was also told by some students that there was some chocolate cyst, sort of this endometriotic cyst was given. So this endometriotic cyst, chocolate cyst, actually revealing thick, dark, brown fluid, history of infertility, and worsening pain, worsening during menstruation. That is the endometriosis of this ovary. That is the chocolate cyst of the ovary. So that also we have discussed. The 65th question. A 35-year-old female male presented with a progressive fatigue, lethargy, and unintentional weight loss over the past few months, and increased skin pigmentation and hyperpigmentation, palms, knuckles, and buccal mucosa also there, and electrolyte abnormalities like hyponatremia and hyperkalemia was also they're given in the history. Some are saying that the lab values of sodium and potassium was given. So hyponatremia and hyperkalemia was the diagnosis. So hyperpigmentation plus hyponatremia and hyperkalemia points out towards a diagnosis of primary adrenal insufficiency. Okay, so as you can see here, the primary adrenal insufficiency is because of this autoimmune, or the autoimmune, that is the most common cause in the developed countries, and the tuberculosis most common cause in the India developing nations, and aldosterone will be low and renin will be high. So this is a case of primary adrenal insufficiency. And the 66th question is, a 25-year-old male presents with a chronic cough, recurrent sinus infection, and increased history of unexplained infertility. And they have given, I was told that someone was told that there was a radiological image they have given of revealing dextrocardia, and the image of a nasal biopsy with increased mucus or a defect in the ciliary structure. So as you can see from here, this is nothing but the Cartagena syndrome. Cartagena syndrome is like a situs inversus. It is a triad of situs inversus, sinusitis, and bronchiectasis. That is the primary ciliary dyskinesia. Moving on from this, primary male infertility. Male infertility. So this is a case of Cartagena syndrome. Cartagena syndrome. So these are the questions, guys, I could collect for this from your recall. And thank you very much for your giving me the recalls and framing these sessions. And the very important point I want to stress for the future aspirants is like high yield topics are the one which they will ask the repeated number of questions. The question need not be like a ditto the same, but the topics they will ask the questions. And also the basic understanding is very important. The concept, understanding the concept is very important. As you feedback from many students, it is like more of like, it is not a simple one liner or just what is this. It's not like a recall of the fact based questions. It is mainly the checking your how you understood the concept. Okay, so it's time to relax. I know that definitely all of you will get your dream seat. Wish you all the best and see you soon in some other session for the future aspirants. Okay, so thank you all.